doctors can pass a lie detector that they are not letting the finances dictate what they give. But doctors get happy when there is a patient who's going to be requiring those medications that are very expensive because the profit for the practice is bigger.
Could you explain financial reimbursement of oncology, how that's structured?
By the time I left oncology, we were down to the ASP plus 6. That means that after the doctor buys the oncology drugs, hundreds of thousands of dollars, 30 to 90 days later, they get Medicare to reimburse them the average sales price of the drug plus 6%. That 6%, that profit is what it takes to pay all the employees, pay the rent, buy all the supplies like IV catheters that are not the chemo. So it's not as good as it sounds. You have to buy the chemo hundreds of thousands of dollars every month ahead of time and then wait until Medicare pays you back. They don't pay you what the doctor paid for the chemo. They pay you based on the average price. Doctors have to affiliate with each other in big groups because when you are a large group, then you have a higher negotiation power and you get lower prices. When I first started in oncology, it was ASP plus 12, so it was a better deal. There was a higher cushion. But in addition to Medicare shipping away the reimbursement, the newer drugs are more and more expensive. A generic chemotherapy drug like cyclophosphamide may cost, $50? While Avastin, I remember at the time I was actively practicing, it was like $10,000 a month. So that creates a little bias. Unconscious doctors can pass a lie detector that they are not letting the finances dictate what they give. But doctors get happy when there is a patient who's going to be requiring immunotherapy, Herceptin, Avastin, Rituxan, those medications that are very expensive because the profit for the practice is bigger.
Mm-hmm. They get happy. Interesting way to express that.
I swear I'm not making it up. There was a lady a lady doctor in a meeting once that we were having where they were explaining the other side of it. The sicker the patient is, the more serious the condition, the Medicare fee schedule pays you the most. That's not only for oncology, that's everywhere. And I'm discussing that in my next YouTube video. So there is the unconscious bias of doctors to wanting to find more diagnosis and to make the case sound more serious. Both for liability protection, again, if you're sick and you die, it's not my fault. Second, for that. And that's why I tell patients, don't believe anything the doctor tells you. Take it with a grain of salt. Don't let them tell you are very sick. No, I decide if I'm sick or not. The thing is that they were explaining this in this lecture, and this lady, when they say, oncology patients tend to be sicker and more complicated, so it's okay to bill the higher codes, she literally said, cash in. I was shocked.
Oh my, yeah.
So
wow.
Yes, we talk about the bias of fear, the fear of malpractice lawsuit. The other big bias that is there is profit, and it's very often very insidious, blind spot. Doctors could swear it's not there. Sometimes it's very blatant, and doctors are literally, clearly calculating what is the most expensive drug I can give.
Yeah. So I guess if the chemotherapy is not working or the patient is really getting depleted, cachectic, and kind of borderline on whether they should get another chemo or whether they should be entered into hospice, there would be definitely incentive or pressure to go ahead and try another chemotherapy.
Absolutely. And I wouldn't call it pressure because there's not an entity chasing us. But that I have shared before, that was one of the last things that pushed me to leave oncology, when I started realizing that there were patients who should have been on hospice a long time ago. And I assume their doctors are having trouble letting go. They are not wanting to accept these patients should be better in hospice. But then a conversation with an accountant made me realize that they felt obligated to keep giving chemo because the financial sustainability of the practice depended on giving a lot of chemo.
What is the difference between a hospital-based oncologist and an independent oncologist?
There's very few or no independent oncologists anymore. You have to buy the chemo hundreds of thousands of dollars every month ahead of time. But if you're a solo practitioner, you're paying a much higher price and you cannot survive. Doctors have to affiliate with each other in big groups or affiliate to a hospital, because when you are a large group, then you have a higher negotiation power and you get lower prices. That was one of my trouble. Even if I didn't like the philosophy of the people working with me, it was impossible to be an individual solo oncologist and afford chemo.
Maybe there are pros and cons with that, because that may mean that hospital-based oncologists have less flexibility. For example, if they're stuck in a standard protocol that hadn't been updated, there's peer pressure, I guess, to do the standard protocol.
I see what you mean. If you're looking for someone open-minded to alternative approaches, that is a hard question, because most oncologists are very close-minded to anything that is not in the book.
And is that due to malpractice concerns or peer pressure or all of the above, hospital pressure?
It is all of the above. First of all, medicine is wired to scare you. If you deviate from the protocol and something happens, you are liable. They're going to sue you. There is also a blind spot. We all were trained that a double-blind, randomized clinical trial is the only study you can trust, that it can really change the standard of care. And yet those cost a lot of money. And if there is a cheap, accessible, free, non-patentable measure, there's not going to be a big sponsor paying the millions of dollars that it costs to run a clinical trial. What I talk about in my YouTube channel all the time is that there is data that love, holding someone's hand, music therapy, having someone look through the window and see trees. There is hundreds of articles saying that free, cheap, available things can drastically impact survival, impact health. But they are not randomized controlled trials because nobody's going to pay for those. So the medical textbooks are based on the information that had the money to make it to the clinical trials, which is usually drugs and pharmaceutical houses, and are lacking seriously from a lot of information that could not afford the clinical trial.
Mm-hmm. And so I'm clearly hearing that fear is driving decision making in oncology. I think that's true throughout medicine. It probably is more so true in a hospital scenario where you can get fired if you don't comply with the recommendations, and the peers may undermine you. As far as imaging procedures in a hospital setting, is there a subtle pressure from the hospital to do regular imaging, even if it is not always clearly indicated?
And it depends on your model, because some practices are affiliated with radiology and some are not. Yes, the bias that if my practice is deriving benefit from PET scans, for example. I know many doctors who push for PET scans or breast PET scans or breast MRIs, things that may not have been necessary at the time because of the benefit. That is balanced a little bit by the insurances and Medicare that refuse to approve them or pay them. So that's a whole different story. Can be a negative force, but at least that sometimes balances. The doctors cannot just order them randomly.
Got you. Okay. Your comment brings up another thought. There's Neupogen, Neulasta. When you administer Neupogen, oncologists make profit off that drug. Is that right? I'd heard maybe up to
especially the long-acting.
$15,000 per treat, possibly.
Yeah. The Neulasta was one of the long form of Neupogen, was one of the drugs we were highly encouraged to use. And that from training in a place where they used to say, oh no, you only use it in people elderly, people with this type of protocols that are known to be myelosuppressant. We were using it on anybody. And the excuse was, the liability. Why would you risk? And it's very hard to argue when someone is telling you, are you going to endanger the life of your patient just to save a few dollars?
Yeah.
So yeah, we were using Neulasta on absolutely everybody. And if you have a question about your health, this is the time to ask it. My channel is early. I have a relatively low traffic. I have time to devote to your questions individually if you send me one via the comments now. And by the way, if this conversation has helped you, please consider sharing it with someone you care for. Tell me what other topics you would like me to discuss in the future and consider subscribing so you at return of medicine to some form of spirituality, and we have to stop calling it a cuss word and bringing it to the table, is going to save physicians from burnout and is going to help patients a lot and even maybe save the healthcare system from bankruptcy. Because when we have the value system that we go back to, I don't recommend treatment that is not appropriate, even if it gives me profit. We're going to save a lot of money to the healthcare system. When we stop operating from fear and we operate from love, we will need to see absolutely everything different. And also, when the patients remember that this life is not all that there is, that it's okay to let go, because when we die, it's not the end. The story continues. Then we're going to see billions of dollars that are wasted in futile treatment, sustaining of life support of people who are already brain dead or in horrible quality of life. Between that and the malpractice fear of ordering unnecessary tests and the profit mentality of physicians, all three of those get tackled if we return medicine to spirituality.